My name is Dr. Richard Klein, R-I-C-H-A-R-D, K-L-E-I-N. I'm a clinical professor at Michigan State Osteopathic Medical School. I teach rounds for about 15 years at Henry Ford Hospital and St. John Hospitals in Michigan. I teach the residents in pain management, and sleep is related to pain management, the physiatrists at Wayne State Medical School, and I'm in private practice. I'm here as a volunteer. I'm not getting paid for this. I'm here just because I went to college to help people, and that's why I'm here. So I'm going to be very honest. I'm here to sort of level the playing field between two very good treatments for OSA, CPAPs, and oral appliances. The American Academy of Sleep Medicine in 1995 came out with the gold standard, a CPAP. And the CPAPs are wonderful. What I do with oral appliances is not better than a CPAP, but it's a lot better than a CPAP in a closet. In 2007, the AMA looked and said, you know, a lot of people won't wear the CPAP. And I heard several people here who I don't know talking about how they tried it and didn't like it. Many studies show that over half the people, no matter how well they know it's important, just won't wear it for a lot of reasons. There was a study, I think it was in Tufts. They took lots of people who had been religious about and very compliant with wearing a CPAP for 10 years or more. And the title of the article when they published it was Smashed Face Syndrome. There was one man in there who said, I married this cutest little girl with a little cute upturned nose, and now she looks like a pig. I certainly hope she didn't read that study. It's embarrassing to her, probably, but that's what happens. There are problems with oral appliances. They can cause TMJ problems. The American Academy of Sleep Medicine said in 2007, if you make an oral appliance, you must be a dentist, because we know occlusion, we know oral anatomy, but you must be a dentist who's well-versed in sleep and in TMD, because the oral appliances could cause a TMJ problem if you bring the jaw forward and irritate the temporomandibular joint. Since a car accident that I was in 1994, I have only practiced two diagnoses, TMD and sleep. And so I'm pretty well versed in it. That's all I do. I brought you quite a few articles that I'll deliver to you after this, since you requested them, and I have them. So, are they effective? They're cost effective. In Michigan, Medicare will pay me about $1,300. In Florida, Medicare pays $1,900 for an oral appliance if someone doesn't want to wear the CPAP, and if they're mild or moderate. A dental device called a denture is a lot more than that. Delta Dental covers 3 times almost that amount, and they're really similar in nature, but they do different things, of course. And the oral appliances are having a lot of studies in the past couple of years since I was previously here with you that show that they're superior overall in one aspect. Most people are more compliant with the CPAP. And if over half the people won't wear an oral appliance is more compliant. If over half the people won't wear a CPAP and over 90% of the people will wear an oral appliance, then they put those two statistics together and it shows some better compliancy and better treatment. The oral appliances were not even looked at, and neither were CPAPs back in the 1970s. This is a new field and it's morphing annually as we look. In order for insurance to pay for something, it has to be useful. So when they found out that most people weren't wearing the CPAP, with the powers that the CPAP employers and people making them had, it convinced the insurance companies that if you wear the CPAP 4 hours a night, 5 nights a week, that's success. To me, that tells me 78% of the time someone is having choking and gasping episodes if they don't wear it 8 hours. An oral appliance is a lot easier. If you're an older man like me, you want to go to the bathroom in the middle of the night, you don't have to take it off. You just walk there and walk back to bed. I tried the CPAP. I'm a scuba diver. I could wear it. But I toss and turn, and that thing would come off my nose, and if I went to the bathroom, I was too tired to put it back on. An oral appliance is more convenient. If you travel, it's convenient too. You put it in your purse or your pocket so you don't lose it. And overall, the success rate, because they're worn better, is high. I'm not saying that oral appliances are better than a CPAP. There's just more compliancy. The cost also, I went over a little bit of that, but with the CPAP, there's continual monthly replacement of parts. Over 10, 15 years, that's very expensive.
Thank you.
You put the oral appliance in, and it's there. They can wear out a little bit, but they don't. Usually like a denture. People grind, they chew on a denture, they wear it out. You put the oral appliance in, and you're not chewing food. You might grind on it, but you don't grind it away like you would with a TMD appliance, so they last. So that becomes very cost effective. We don't want the terrible tragedies of OSA to be with trucks and with trains. When I said I was late almost last time, you probably would have said you should have taken a train. And I like trains. On the plane here, I met an attorney from DC. He was in Detroit doing some work. And we started talking. He wears a CPAP. He's a young man, a little bit younger than you even. He's probably about 30. I think you're probably about 31. But his father died. He had a stroke. A year later, he had a heart attack. 20 years ago, they weren't looking at it as sleep apnea. As you medical members know, and maybe people listening don't know, every cell in your body needs oxygen. So if you're depleting those cells of oxygen because you can't breathe, and you also cannot exhale, the carbon dioxide is very acidic. If that remains in the cells and you don't get the nutrition of oxygen, every cell deteriorates. So sleep apnea not only is dangerous for someone to fall asleep going 80 miles an hour on a curve on a track that was supposed to be stopped to 30 miles, or a truck driver falling asleep, it causes type 2 diabetes, ADD, concentration problems, high blood pressure, stroke. I could go on for hours just mentioning all the little things that it could exacerbate. That's how valuable controlling sleep apnea is for the average person. It's more important with transportation because the NIH did a study and it shows that drowsy driving is more dangerous than drunk driving. If you are inebriated, you could see something and turn. If you're falling asleep, that truck or that train just continues at the same pace, and it's dangerous. So controlling sleep apnea is not only healthy for each individual, but it's going to save lives if we do that for all of America's rails and roads. I've been doing this for quite a few years. I've seen over 10,000 patients for the 2 diagnoses. And basically, I see people who just don't want to wear their CPAP, and they are so happy afterwards because now they're controlling their apnea. Now, you mentioned about moderate or severe. Medical insurance won't pay for severe because it won't work. It does work sometimes, but it won't work. So there's lots of alternatives. You medical people, you know that. I had a lady that was 52 AHI. AHI, for those on the internet, apnea hypopnea. It's how many times you stop breathing and almost stop breathing per hour. And 5 to 15 times an hour is mild, 15 to 30 is moderate, 30 and above is severe. And I've seen people over 100. I don't know how they could live or walk. This lady was 52. And she couldn't wear the CPAP, so that was it, according to the sleep doctor she was seeing. So I got a hold of her polysomnography study, and it showed that she slept supine on her back 60% of the time. Well, I told her to get a little, either sew a tennis ball on her back or wear a fanny pack, and I did a home study, and it was down to 33. Well, that's still severe. It's still a problem. But she had broken her, and more talking to her, she had broken both ankles 2 years ago. And she had gained 25 pounds. And she's in therapy now, she can walk. And I explained the danger of sleep apnea. And I told her that insurance will pay for if it's 29.9 or under, being moderate. And if she lost 10 pounds, probably she would lose the weight here enough to create it with an insurance capability of paying for an oral appliance. So she went on a diet. Now she wears an oral appliance and she sleeps well, and that was severe. But there's other factors. Someone else I heard talking back here, before bed, don't have alcohol, don't have caffeine, don't smoke, sleep in a dark room. When you're smoking, it expands inflammation. Even if you smoke, your throat swells up a little bit. That constricts the airway. When you have alcohol, it relaxes you so much, and the airway can collapse. I've been saying this for years. As we age, the throat muscles lose their tonicity, and they can collapse more. I was lecturing in Scottsdale just recently, and a female sleep specialist said it so much better. She said, as we age, everything sags. And that's what happens in the throat, too. When these muscles sag, unless you play the didgeridoo and you're playing 8 hours a day, 7 days a week in Australia, these muscles do sag. Look at Schwarzenegger compared to what he used to look like. So my message here is that if we level the playing field and give everybody, not only the transportation, but especially them, because when they fall asleep, it's not like the attorney I met, he said he fell asleep at his desk. Well, that wouldn't bother you unless you missed an appointment with a judge. You just fall asleep and wake up. If you fall asleep and you're traveling, whether you're in your own car or driving a truck or with a train, there's consequences, terrible consequences. And I think we're here to try to help that. Thank you very much.
Thank you. If you would just stay at the microphone for a minute in case the panel has questions.
Sure.
A couple of questions for you. When you had started off the description of the oral appliances, you indicated that the oral appliance is better than the CPAP in the closet. Could you share with us any information you have concerning how you would measure the effectiveness of the oral appliance? How do you see how frequently the patient actually uses the oral appliance? With the CPAP, you have the ability to collect all the data to see how many hours per day and how many days per week they're actually using the CPAP. Do you have any idea of how we would go about assessing the effectiveness?
Yes, Larry, a good question. And in the older days, 10 years ago, that was a big issue. The CPAPs were able to be determined, the utilization. But if you look on the internet, there is how to cheat with CPAP tests. It tells the people how to take the CPAP and verify it supposedly without even wearing it. It's a scam, but a lot of people don't want to wear it and they don't want to lose their jobs. What that means is they're dangerous still. So because of that, the oral appliances now can have a chip in it, and that chip will tell the computer how many times they used it, when they used it, how much they use it. So to answer your question, the compliancy chip will now do exactly what was in the CPAPs prior to the Dr. Rick Bonato invented the CPAP chip. There's a couple other companies that do that, and they're measured now too.
And I guess another technical question before I turn it over to the doctors. I don't think you mentioned whether there are some specific studies that talk about the effectiveness of the oral appliance versus the actual CPAP, so that if you had two scenarios, one where the person actually used the CPAP on a regular basis versus how effective would the treatment of their OSA be if they used the oral appliance, something that compares the two of them?
There's studies on that now, and as I said, the gentleman I met on the airplane, the attorney, he's happy with the CPAP. So my job would be, good job, nice, keep it up. The oral appliance would not be indicated in that case. It's only indicated if they don't want to or won't wear the CPAP, or if sometimes they travel or don't want to take it. Some people have both, especially hunters up in Michigan without electricity. The CPAP needs electricity. I'm sure they're going to be making ones with good batteries, but they still need electricity. The oral appliance needs your fingers to put it in your mouth.
Thank you, Dr. Klein. I have two questions.
Sure.
First, as far as your practice is concerned, how do you evaluate someone that you have designed an oral appliance for to determine that it is effective as far as reducing the AHIs? And secondly, what parameters would you recommend be used in following these patients, in that we know if someone has severe OSA, like your patient, and they lost a certain percentage of weight, then that changed the degree of OSA because of the change with the anatomy to some extent. So in that case, what parameters do you use in reevaluating your patients who have some type of change such as that?
What I do is I have several of the home tests. Now, Insurance does not pay a dentist for the test. So I explain in detail, this is a screening, and I will work with your sleep physician. And that is the right way to do it. The American Academy of Sleep Medicine says that you, as an MD or a DO, need to diagnose it, but the oral appliance must be made by a dentist well-versed in sleep and TMD. So when I make it, I put it to the most logical, probable position, and that's a guess. And then I do a home study. I wait till they wear it a couple weeks so it becomes part of their normal sleep hygiene, because you put something in the mouth, it's going to take you a couple days to get used to it. Even the athletes that wear mouthpieces take a little while to get used to it. Once you get used to it, you're having your normal sleep, then I'll see what their AHI is, and I'll see their oxygen rate and their sleep position. And if it brought it down to only 10, I'll advance it. Oral appliances are advanceable, just as CPAPs could increase the pressure. And so to answer the other part of your question, as we age, I check them once a year. And basically, I just charge an office visit for it. And usually Medicare, Blue Cross, any insurance pays for an office visit. The screening for me is just part of what I want to do to help the patient. You're welcome.
Thank you again for your comments. You talked about the oral appliances having to be designed by a dentist who has this kind of certification and extra training. Do you know about how many dentists across the country have this additional training to provide the service so that these folks who are non-compliant with CPAP can actually get the oral appliances?
I can't give you a number, but I can talk about it. 5, 6 years ago, not too many dentists were doing it, maybe a few hundred. Now there's thousands. Unfortunately, a lot of them are not well trained in it. And there are some problems because they can cause side effects. And if you're not versed in how to treat those side effects, that could be a problem. But I think most dentists would not want to get involved with making an oral appliance unless they studied a lot on it, because it's not what's taught routinely in dental school. When I went to dental school, they didn't even know what TMJ was back then. And that's a good example, too, because TMJ problems are now mainstream in medicine. But I was laughed at in the 1970s. They called me the voodoo doctor because I was fixing headaches with a piece of plastic, and that works for TMJ. We're seeing this now with sleep. It's becoming more and more understood. It wasn't even studied till William Dement in Rush University started in the 70s looking for it, and he admits, I put everything together in the test and called it a polysomnography, poly meaning many, somno with sleep, many tests. He says, well, we really don't need all of that. He's right and wrong. I'd rather you do that test and look at blood pressure, look at all the things that the home screening doesn't show. The home screening will tell me just the oxygen rate, the amount of AHIs, and that gives me good information. But that doesn't tell me about all the other things you as a medical professional should be looking at, and that's not my job. My job is to help you with the people who won't follow your advice of a CPAP.
And just another question, and I might have missed this. You talked a little bit about insurance reimbursement for the oral appliance from a Medicare perspective. Mm-hmm. Are you familiar with, and private insurers vary across the country, but are you familiar with kind of whether or not private insurers cover this on average, or is this still an issue as well?
It's not the issue it used to be, and private insurance pays more than Medicare, which is true with anything we do. And the reason that it's becoming more and more acceptable, and almost everybody accepts it now unless there is a clause in it. Sometimes a Blue Cross will have a very inexpensive plan that doesn't cover a lot of things, but the majority of them do cover. And the reason they cover it is they know that long range, those people are going to be healthier. They're not going to have all of the other problems that are caused or exacerbated by lack of oxygen. And so they like this. It's a less expensive way of them taking care of that patient for 20 years. So most private insurances are paying exactly what I need.
Dr. Klein.
Yes.
Curious, do you know the percentage of patients that you have that you're treating with the oral appliance that work in the transportation industry?
Well, I'm in Michigan, and most of my patients are not in the transportation industry. But those who I see are the ones who want to follow the rules and just won't wear the CPAP. So on a percentage of my patients, I don't know, maybe 5, 10%, and 10% might be high. But I have a lot of people that work for Kroger's or Walmart, and it's Detroit is not like D.C. There's a lot of people that don't have jobs there right now. It's coming back, I'm proud to say, but the transportation industry from Detroit leaves Detroit and comes back, and there are a lot of truckers there, and I'm seeing some of them, but it's not the major part of my practice.
And do you find that the patients are being referred to you from the sleep specialist because of the non-compliance with CPAP, or how are they getting to you?
For a variety, that is one of them. Most of my referrals come from ENTs because they're looking at a lot of things, both of which I do the TMJ. If you have ear pain, that could be a TMJ problem, and a lot of physicians don't understand that the ENT people know that. But the ENT people are looking at the Mallampati scores if they know what they're doing, and if a person has sleep apnea, they'll refer to me if they don't want to wear the CPAP, and I will then work with their sleep physician, a DO or an MD. You're welcome.
Are there any other questions for Dr. Klein? Matt?
To kind of follow on Camila's question, you mentioned the cost for the oral appliances that Medicare pays. Are you aware of the costs that Medicare pays for CPAP machines?
I don't do them, so I don't know that. I think from what I've heard from talking to my friends who are sleep physicians, the cost is going down, and CPAPs are not as expensive as they used to be. But there are still costs of the other parts that have to be repaired or added to it or replaced, where you don't have that cost with an oral appliance.
Okay, thank you.
You're welcome.
Any other questions? Thank you, Dr. Klein.
You're welcome. First, I'm pleased with all the tenure of all of these very meaningful, moral, honorable discussions here. I'm also representing the American Sleep and Breathing Academy. They've asked me to put forth what I'm talking about here. The ASBA is the largest sleep organization in the country because it encompasses everybody who deals with sleep, all the professionals. There's about 300 or 400 dentists in it, that's it. I'm on the board of directors and the treasurer of that part of it. But there are sleep physicians, there are the technicians you talked about that someone called the polysomnograph. There are many, many people in this organization that deal with all different type of aspects of sleep, which is kind of what we're talking about here today. So, someone asked about the burden and the benefit. Well, one of the things that there is a peer-reviewed published study on and documented positively by other studies is that in the world, 80% of the people who have sleep apnea do not know they have it. That's a big study. That affects what we're talking about here with the truck drivers and everybody. They might have it, they don't know they have it. And I fit into that category. As I told you before, I was in a car accident, I was doing pain management, and about 2 decades ago I decided I'm interested in the sleep. So the way I learned pain management is I had it, and when I was studying I recognized instead of memorized it. So I thought, well, I'm going to be a patient. Well, I'm a typical guy. My wife said I snore. Occasionally I was fatigued. I had sleep apnea. Didn't know it for all those years. So I tried the CPAP. I'm a scuba diver. I could wear the CPAP. I just find the oral appliance easier to travel with. So I could wear the CPAP. And like I said before, the CPAP is wonderful if you wear it. But if you don't know you have sleep apnea, you might be out driving not even knowing about it. So the burden and the benefit, here's how I look at that. After I recovered from spinal surgery, I went to a gym. Now, that cost me money. That cost me time. 3-4 times a week I'm in the gym. I have to drive to it. So you're talking 5-6 hours every single week that I'm not producing, I'm not working. What's the benefit? I am healthier. I can think more cognitively acceptable to my patients. I can be a better provider for the health of my patients. I think that benefit is deserved by everybody in the country, including everybody we're talking about here. They deserve that benefit. And the problem that I see you having is there's different sides to it, and your job, Larry and everybody else here, is to listen to all of this and try to make it more efficient. Because to deny them the access to see if they have sleep apnea just because they have an 18-inch neck, might be very beneficial to think around that denial. So truck drivers, pilots, train engineers, they deserve the same benefit. Somebody brought up fatigue. Now, this is another problem. Most physicians, not you, but most physicians in America don't know much about sleep. So is their exam including sleep apnea? Probably not. That could be an education issue you might want to consider. If you're educating the public and educating doctors on what to look for, we might save a lot more lives. A really good example, just this week, Donna has been my assistant for 25 years. I know her husband intimately. He's a nice guy. He's a minister. He's gained a little more weight every year. He had a stroke 2 weeks ago. And Donna, who knows what I do, asked his physician, do you think he could have had a stroke because he has sleep apnea, because he weighs 300 pounds? And the doctor says, oh, I don't believe in that sleep apnea stuff. That's a fact. We need to educate both sides. Doctors, not you good doctors, but a lot of them don't know what we're talking about. That's an issue that I think would be nice for you to consider. And home testing and the designated sites, I'm not sure, but if you put them on the interstate connections, it might be easier for the drivers to pick it up, sleep in a hotel, sleep in their home, not worry about taking that time off like many people have brought here. That could be an issue that could be very cost effective, or at airports or at train stations. The compliancy chip, someone asked me about that. They're concerned that they won't know how many people are wearing appropriately the oral appliance. The compliance chip is based on body temperature. So when you take it out and put it in a drawer, it's going to be room temperature, 70, 80 degrees, depending on how you keep it, 63 if you're my wife. She likes it cold. But in your mouth, it's 98.5, 98.6, 98.7. That's how it's compliant. They can tell. So, a couple questions that were asked, and in what I brought to you, these are covered already. So I'm not going to read the whole thing, just about a half a sentence from each one. One of the gentlemen mentioned an article that's going to be published in Sleep. I kind of think this is the same article. It was published in March 22nd of this year. That's pretty recent, in the Journal of Primary Care. It says, results show that the rate of serious preventable crashes was 5 times higher among truck drivers with sleep apnea who failed to comply. Another March 24th of this same year, a Drive report reveals the results of a survey that showed 29% of more than 4,000 motorists admit they fall asleep while driving. This one says drowsy driving may be responsible for 1.2 million accidents every year, according to the National Highway Traffic Safety Administration. And this one is what we were talking about before. The last one I'm going to read, you've got it all there with more than just this sentence. Given that the risk of heart disease, cancer, diabetes, dementia, premature death are similarly increased in people with untreated obstructive sleep apnea, regulatory agencies worldwide owe it to truck drivers and to the motorists who share the road with them to require objective screening, diagnostic testing, and treatment adherence. And that was from the American Sleep AASM just recently. So I'd like to say I'm honored to be here, and you guys have a big challenge. And you heard a lot of different ways that you might not have considered that are probably important for your challenge. And if you would like to have an advisory committee, I'd be honored to accept your invitation. I'm sure there'll be a lot of people in here who did some good work for you. Because you need the information from all different aspects. The man who was spouting off anger, he had it in his heart. That needs to be fixed too. So I appreciate what you're doing, and I know you have nothing but the highest integrity trying to fix this problem. And it's a problem with many different solutions, and God bless you with doing it. Thank you.
Would you like to speak again, Dr. Klein?
Dr. Klein, K-L-E-I-N again, and I appreciate what I just heard. Malampati was an anesthesiologist who invented the score, which tells you how much room there is in the throat, so that he could find what kind of tube he would put during anesthesia. It's good for sleep apnea, just like he said. The problem I see is what I mentioned before. I don't think most physicians know the Malampati at all. Again, going back to education, I agree with what he said. That could be a wonderful screening, but not if doctors don't know how to do it.